Good evening. I hope you will forgive my southern accent. I was so pleased to see that there is a young woman from Italy who is here present, and I hope she may help me if we have any problem with my accent. But please, I will try to speak very slowly, and I hope that there won't be any problem. I am extremely honored to be invited for the second time to address this audience. And that is very personal, because I have been chief of oncology in several different VAs for almost 8 years before I moved to Moffitt Cancer Center. And my work started at the VA, and I never expected to see the VA to flourish in the way that it did. So I want to congratulate all of you, and I want to wish you the best work. I think that your system has probably the clue to the management of most cancer patients, and particularly of the older cancer patients. And I wish that this would be carried on. I also would like to remember a very good friend who is still alive but is not here with us today anymore. Many of you know him. Dr. Hussain Saba is one of my best friends. He's the one who introduced me to the Florida system. And I don't know if he was past president of your association, but in any case, I want to tell him when I go back to Tampa that we have all thought of him. Thank you. Okay, I would like to start with some data. And as you know, there are about 700,000 physicians in the United States that cause 120,000 accidental deaths every year. So a number of accidental deaths for physician is 0.0171 per physician. At the meantime, there are about 80 million of gun owners that cause approximately 1,500 accidental deaths every year, and consequently, the number of accidental deaths for gun owners is 0.0001. You don't need to be a statistician to realize that doctors are 9,000 times more dangerous than drug owners. I have to present this data because I come from the state of Florida, and our Governor Scott, threatened in many occasions to close all 3 cancer centers of Florida. But in the meantime, he never tried to close any of the loopholes that there are for the possession of firearms. So the governor feels very strongly that we should eliminate physicians rather than gun owners. You see, not everybody has a gun, but almost everybody has at least one physician. And you can hear all of this. I don't talk anymore about lawyers because both my son and my daughter-in-law are lawyers, and so I really cannot pick on them. But I wanted to share you these statistics, first of all, because I am obliged to do so by the governor of the state of Florida, but second, because I'm kidding. Not even Governor Scott would, he would love to, but he does not have the power to do that. But second, because I would like to emphasize that physicians may kill patients not because they treat patients too much, but because they don't treat patients enough. This is a meta-analysis of treatment of large cell lymphoma in patients aged 60 and older or younger than 60. And as you can see, when older patients were receiving the same dose as younger patients, they had exactly the same survival. But when they were receiving the lower dose, their survival was much lower. This is an Italian study from Dr. Zinzani showing that irrespective of your age, whether you are younger than 70 or older than 80, if you obtain the same dose of chemotherapy, you have the same rate of complete response. This is another study, a study from France, showing that in older individuals with non-small cell lung cancer, a disease which is really not curable, the doublets of a platinum compound and a taxane or another new drug is superior to the single agents of chemotherapy. And there are a number of data from SEER, you are familiar with SEER, surveillance epidemiology and the result, showing clearly that the use of oxaliplatin and 5-FU is superior, or the use of irinotecan and 5-FU is superior to oxaliplatin alone in people with this cancer. I don't want to dwell on this too much. So I think that the first point that I really would like to emphasize is that older age by itself is not a contraindication to the treatment of cancer. Age by itself is not a reason to reduce the dose of cancer treatment. And doctors may kill the older patients not because they treat them too much, but because they don't treat them enough. With this premise, let's see what personalized care is about. We talk a lot about personalized care. At Moffitt, in our cancer center, we mainly consider the personality of the cancer, which means the biochemistry, the genomics, the proteomics. There is less interest in the profile of the patient, which include life expectancy, treatment goals, and treatment tolerance. This is a very important, I think that both profiles need to be assessed because the treatment plans need to be based on both profiles. Definitely, to be able to have a molecular profile of cancer has allowed us to make decisions which are much more, much safer for the sake of our older cancer patients. But we should never forget this profile and to find out whether we can improve the life expectancy of the patients, whether we can improve the quality of life, what the treatment goals and what the treatment tolerance is. And also, I think it's always very humbling to remember that there are a lot of things that still we don't know, and the thing that we really don't know is the tumor-host interactions. We know that the immune response declines with age, and generally that is associated with a more aggressive cancer, but in some cases, like breast cancer, the opposite may be true. We know that insulin resistance is associated with an increased cancer growth. We know that the inflammatory response is responsible both of stimulating the production of new carcinogens. We know that polymorbidity will affect the benefit and the risk of cancer treatment. And we know that polypharmacy also may affect both. I am sure most of you are aware that metformin, a drug used to treat diabetes, has been associated with an improved prognosis of breast cancer because it has reduced the circulating level of insulin and accordingly has reduced the stimulation of the tumor growth. Does the tumor profile change with aging? No question about that. I don't need to mention about the changes in the case of acute leukemia. In the case of large cell B-cell lymphoma, we learned recently, in the last 3 or 4 years, that the prevalence of activated B-cell lymphoma and Doppolite lymphomas, as well as EB virus lymphoma, increases with age, and that may be responsible in part of a poorer prognosis. And the common wisdom tells us that breast cancer is more indolent in older women. And although that may be true, there are a number of disturbing data showing that the mortality of breast cancer increases after age 65. The most important data came from the Netherlands, but a very recent study came also from California, So there is something going on there that we need to explore more in depth. For what concerns the patient profile, we need, of course, to know how long the patient has to live, whether the patient is going to die with or of cancer, whether the patient is able to tolerate the treatment of cancer, whether the patient has a socioeconomic support to supply to the limited functional reserve, and if there are changes in organ function, such as the kidney function, that may alter the pharmacology of our medications. But it's also important to establish what are the goals of treatment. Cure, prolongation of survival, and symptom palliation are the goals of virtually any treatment. But in the older patients, it's very important to add active life expectancy. Active life expectancy is the period of time during which the patient is independent. For the majority of older patients, the loss of independency is probably one of the worst threats to their quality of life. And certainly, some of our medications, in my experience, mainly the neuropathic medications, may affect this life expectancy significantly. And here we go to the issue of physiologic age. Probably those of you who were here, who were at this meeting 5 years ago, saw these pictures already, so I apologize for that. But this is a picture of my twin aunts at their 90th birthday. Although these two women were made of the same genetic material, they grew up in the same small town in northern Italy. They exercised the same profession of elementary school teacher. By age 90, they could not be more different. This aunt was completely independent and remained independent almost until her death at age 102. To tell you the truth, at age 95, she quit driving. But knowing the conditions of the Italian roads, I think that was more a sign of maturity than a sign of age. This aunt over the other side was completely demented, and she died 1 year later, not even knowing whom I was. Clearly, if this aunt had developed lymphoma, I would have treated it very aggressively. If she had developed breast cancer, I would have given to her adjuvant chemotherapy, but I would have never given an adjuvant treatment to this, or a very aggressive chemotherapy treatment to this woman. Same nature, same nurture, quite a different outcome. That's why we need to have a very valuable estimate of what the physiological age of the patient is. How do we assess it? We cannot count much on the laboratory assessment, and the clinical assessment is still probably the most effective one. However, I would like to mention, and probably my friends who work on coagulation will be happy to know that, you know that aging is a progressive and chronic inflammation. And the number of inflammatory markers, including D-dimers, increases with age, C-reactive protein, and is associated with a poorer outcome. This inflammatory index is a combination of two things, of the log of interleukin-6 plus 2 log of tumor necrosis factor receptor B. And as you can see, that has been obtained through analysis, been validated in 2 studies, the Baltimore longitudinal study and the Chianti study in Italy. And as you can see, it relates very well with the survival of the patients. So there may be something about that. The only problem is that this has never been tried in cancer patients. Cancer itself is an inflammatory disease, so I think needs to be validated in cancer patients, but I think it's very promising. The other test that has been very sexy, let's say, has been the telomere length, but I don't think that the telomere lengths are going to be very useful in assessment of individual age, because as you can see, there is a big variability. They are very useful in epidemiological studies, because when you look at average, the people who are physiologically older have a shorter average length of telomeres. But so I don't think that there is much future in telomere length, although some of my friends in France have demonstrated recently that the telomere length is associated with increased risk of toxicity of chemotherapy. So far, the only validated assessment of physiologic age is the comprehensive geriatric assessment that involves the assessment of these different domains. The activity of daily livings, I apologize for the nurses in the audience, but I'm sure the physician need to say the least a refresh of that, include continence, ability to wash, to get rest, to transfer, to go to the bathroom, and to feed. If you are dependent in one or more of these activities, probably you are at the end of the road. You don't have much of a physiological reserve. Careful, however, very careful. Remember that there is a big difference between disability and handicap. In other words, if a person is paralyzed because he had a stroke 10 years ago or because he had a car accident, but he learned how to use a wheelchair or how to use an elevator, that person is not dependent in activities of daily living. That person has a disability but does not have an handicap. Is that clear? It's very important because the disability is medical, the handicap is man-made, and as long as you can compensate to the handicap is not present. Oh. More important, however, are the so-called instrumental activities of daily living, which include use of transportation, ability to take medications, to provide to earn meals, to go shopping, to use the telephone, and to manage one's finances. I don't know why, probably because most geriatricians are women, these two types of activities have been added. I'm not sure exactly what they are, but I can tell you that if you ask my wife, she will tell you that I've been dependent in these activities all of my life, and I plan to remain dependent now that I'm 70 years old until I die. I know it sounds very self-serving, but there was a beautiful French study done in 1999, Barbara Gigateau, showing that these two activities have no prognostic value whatsoever. However, if you are dependent in one or more of these activities, a different story. Then your risk of dementia increases by 50%, your risk of mortality increases by 50%. And I would say that the instrumental activity of daily livings are to some extent the performance status of the geriatric oncologist. Plus there are the geriatric syndromes, delirium, dementia, depression, incontinence, falls, failure to thrive, and neglect and abuse. To that we should add, I didn't have a slide yet, to dizziness, continuous dizziness, and fear to go out is another geriatric syndrome. Again, this geriatric syndrome may be associated with some of, the very end of life. However, remember the delirium, I mean, if any one of us here in this room has a bacterial meningitis, clearly we have delirium, but that is not a geriatric syndrome, okay? Or if we take LSD, this is the delirium, but it's not a geriatric syndrome. Delirium is a geriatric syndrome only if it develops in the presence of minor infections, or if it develops in patients who are taking anticholinergic medications that normally would not cause it, okay? And falls is an important problem. I don't know how many of you remember the Nobel Prize work of Garcia Marquez, The Love in the Time of Cholera. That is a beautiful book on aging. And he said, siempre pensaba que con la primera caída viejez e con la seconda llegaba la muerte. He always thought that with the first fall arrived the aging, and with the second one arrived the death. That is a very important and needs to be evaluated more carefully. These are the polymorbidity that increase the risk of dying. I would like to emphasize that cancer is not redundant to talk about cancer, because about 20 to 30% of cancer patients aged 70 and older have a second cancer or a third cancer. And by the way, this is for another time. Maybe you will invite me at another meeting if you're not tired of my joke. But, right now there is so much discussion about evidence-based tests, what is helpful and what is not helpful. But the truth of the matter is that more tests you do, more things you find. This is a kind of an extreme, but I had a man in his old 70s, late 70s, from Iowa, a farmer from Iowa, that was spending the summer in Florida. And for some reason, his primary care physician checked his PSA, which I don't approve of at all. I don't know what my PSA is, okay, a 70-year-old. Anyway, the PSA was slightly elevated, so the primary care physician got a CT scan of the abdomen, and surely enough, he had a big mass in the kidney and a lot of lymph nodes. We did the biopsy of one of the lymph nodes, was a low-grade lymphoma, so we removed the kidney. He did well for 3 or 4 years. Since I was following the lymphoma with regular CT scans, one day the radiologist called me in a panic saying, the man has a left atrial myxoma. He was getting ready to drive to Iowa that same day. Of course, that is always the way it happens. I could not stop him from doing that, but fortunately, as soon as he arrived to Iowa, went to the Mayo Clinic and was operated upon. And eventually his lymphoma progressed and we treated it. So yes, the PSA, the only thing he did not have was prostate cancer. The PSA was not indicated in that case, but more tests we do, more things we find. And I think that is something that we don't consider enough when we talk about cost effectiveness. Anemia is extremely important. Again, that can be a topic for another time. Why is comorbidity important? Well, of course, comorbidity decreases life expectancy and increases the toxicity of treatment. But the comorbidity may also affect the prognosis of cancer and may cause polypharmacy and drug interactions. In a study that we just published, we demonstrated that the higher was the risk of drug interactions, even for drugs that were not related to the treatment of cancer, higher was the risk of chemotherapy-related toxicity. And as I already mentioned, some of the drugs may promote the growth of cancer, other drugs may benefit the growth of cancer, like metformin. And as you know, diabetes is associated with the worst prognosis in colon cancer, breast cancer, and prostate cancer. So we always have to think about cancer as a mobile target. Comorbidities is not just something which is there, it's something that influences what is going on. And with the other benefit of the geriatric assessment, this one, I won't spend much time about that, but I would like to emphasize that the evaluation of the caregiver is extremely important, because without caregiver, proper cancer treatment cannot be administered. When I started working at the VA in Jackson, Mississippi, in 1978, that's when I started to be a staff oncologist, I had older patients with small cell lung cancer, metastatic. And at that time, small cell lung cancer was the only form of lung cancer that could be treated. And the two daughters told me, we don't have time, we have no intention to help him come into the clinics. And I told him at that time, they were a different time, by all means, for 40 years ago, please remember that. But I told him that for him there was no treatment. Did I lie to him? Probably not. Was I candid with him? Probably not. But that is not the issue. It's not my ethical problem. What I want to discuss is the fact that without adequate caregiving, there is no way to administer an adequate treatment for cancer. And, oh boy, no. Finally, how do we put all this together? This is what most of you are familiar with that. This is a study coming from another VA, the San Francisco VA. I don't know if anybody's here from San Francisco. No, that's because San Francisco is really, the San Francisco VA for me is the best place to learn how to study geriatrics. Okay, Louise Walter is one of my role models in medicine. Dr. Lee was a resident when he did this study. And Dr. Urman now is a doctor, but when she published the study on e-prognosis was just a medical student, to tell you what. And they have been able, through a large group of databases, to establish how the mortality of the patients can be. And the problem, what I want to see, this is not the only model. If you want, are you familiar with e-prognosis or not? Anybody is? E-prognosis, if you look e-prognosis, there are several different models. But the thing I want to see here is that, as you can see, if the score based on function and comorbidity is very low, the mortality rate is very low irrespective of age. If the score is high, the mortality rate is very high. This instead is a model that we created, the so-called CRASH model, based, as you can see, on physical finding, chemotherapy, but also geriatric assessment to establish the risk of hematological toxicity and non-hematological toxicity in older patients. You can find them online on Moffitt SAOP. That is all of our instruments are online. And this is the other instrument that Arthur Ria developed at the meantime, that we think that ours is better, of course, but anyway, hers too involved a number of elements related to the geriatric assessment. And the other thing is very important, low anemia is an independent risk factor for cancer, for chemotherapy-related toxicity. So, what I would like to say to conclude is this, is that geriatric assessment right now allows us to establish, to estimate a person's life expectancy, estimate the risk of chemotherapy-related toxicity. We need to perfection, to keep fine-tuning this instrument, and I hope that will be done at the VA because you have the best opportunity to do that. But right now it's probably the best instrument to establish that. Now, I just would like to, aging has been defined in Boston as a loss of entropy and the loss of fractality. Anybody knows what fractality is? Okay. A fractal, let me give you an example. Anyway, I'll give you a story with Viagra. A fractality is, a fractal is like a branch of a tree. You know that each branch will divide in more branches, but the length and the number of each subdivisions is unknown. That's what a fractal is. And we have a lot of fractals in our body, especially in the nervous system. When I heard the first time this talk in Baltimore, the example of the loss of fractality was this. It was an Israeli man that was working with a nurse, and he was 85 years old, and when he was working with the nurse, he was doing fine. But as soon as the nurse left him, he fell down. So clearly he did not have any neurological finding, but his nerves could not work together, and that is a loss of fractality. And now allow me to give you an example of loss of fractality based on Viagra. When Viagra first became available, a couple of elderly couple decided that it would have been fun to find out if the husband was still fertile. So they went to the physician, and the physician gave them a sterile cup and say, come back tomorrow with a sample. And they leave all unbeaten. The following day they are back and they are very chagrined. The wife cannot even talk. The husband can talk but cannot establish eye contact, and the container is empty. What happened? Asked the doctor. Oh, doctor, said the husband, looking at the floor, I was terrible. I tried with my right hand and with my left hand. My wife tried with the right hand, with her left hand, and with her mouth. We called our next door neighbor, and she tried with the right hand, with the left hand, with her mouth, and with the kitchen rag, and nobody succeeded in opening the cup. So, if you want to think about loss of fractality, that is a loss of fractality. So, these are the questions. Is the patient going to die of cancer or with cancer? Is the patient going to live long enough to suffer the consequences of cancer? Is the patient able to tolerate the cancer treatment? What is the desired outcome of the treatment? Please let's remember what I mentioned before, the active life expectancy. And last but not least, does the patient have an appropriate caregiver? What about, so this is the first part talking about patient profile and cancer profile. I hope I gave you a good overview of what the patient profile should be like. As you know, people are, aging may be considered a progressive loss of function. But this loss, as I showed in the case of my aunt, is different for different people, occurs at different rate for different people, and within the same people occurs at different rate for different functions. Well, another joke, and I promise I will be good after that, but there is an older man that look at two younger men playing golf and ask them, can I join you? The two youngsters sneers at him. Old man, you are so old that you probably, you are welcome to come, but remember that we are playing a very hard game. And if you have a heart attack, we won't even stop the game to call 911. We'll let you die on the field. After about 2 hours, the old man has beaten the two young men of about 9 strikes. So they are kind of pissed and go to the country club and start playing cards. Again, the old man asks them, can I join you? Okay, old man, but remember that we are playing a very hard game with a lot of money, probably more money that you never saw in all of your life. Don't complain with us if you, at the end of the game, you will go to the poor house. After 2 hours, the old man is much richer, and the two young men are broke. So one of the young men say, okay, old man, enough with niceties. Here's nothing wrong, okay? I thought you lost something with age. Instead, it looks like you got better in golf, you got better in cards, you got better in everything. Let me ask you very bluntly, do you lose anything with aging? The old man that up to this moment was very upbeat and becomes very chagrined, looks down and says, you are so cruel, my young friend, to ask this question. Yes, you lose a lot with aging. Let me tell you this sad story. Last night I was in bed with my wife. I woke up around 4 o'clock. I turned to her and I said, honey, I would like to make love. She turned to me and said, oh, come on, it's the 4th time tonight. I am very tired. It looks like you never get enough. That's what you lose with age, memory. Anyway, there are some things that you lose with age, and in pharmacokinetics, definitely the renal excretion of drugs is decreased. The metabolism of drugs, at least the phase 1, the cytochrome-dependent metabolism is changed. The volume of distribution of water-soluble drugs is also decreased. And certainly there are some organs that are more susceptible to the toxicity of chemotherapy. These are 9, how many are they? Yeah, 9 studies showing clearly, I should have added arteriureas, that anemia is associated with an increased risk of myelotoxic complications. And the reason is simple, is because the majority of our drugs are heavily bound to red blood cells. And so if your hemoglobin drops, let's say, from 12 to 8 grams, the percentage of free drug in the circulation may increase as much as 25%. No question that age is associated with an increased risk of neutropenia. This is a study that Dr. Lyman did more than 10 years ago, reviewing 500 patients treated in the community with CHOP and CNOP. And as you can see, the risk of neutropenic infection was 40% in older patients, 18% in the younger one. So clearly, age is associated with and furthermore, age was associated also with an increased risk of hospitalization. Very important, the risk of neutropenia is mainly high during the first course of treatment, and this is a systematic review by Dr. Kuderer, who is the wife of Dr. Lyman, showing that for the first time, the first and only time, that the use of growth factor in this patient is associated with decreased mortality. In addition to that, let's not remember that a number of complications are increased with aging. A few years ago, I was in Denmark discussing exactly the long-time complications of cancer chemotherapy. No question that the risk of AML and MDS increases as a result of chemotherapy in older women with breast cancer. Hopefully, this problem will not be a problem anymore with the tumor profile, because the oncotype will tell us really which women do or do not need that chemotherapy, and many of the women that were unnecessarily treated will not be treated anymore, but that we have to take responsibility of this serious complication. The risk of cardiomyopathy increase has definitely been demonstrated in at least 3 groups of patients, breast cancer, lymphoma, and small cell lung cancer. However, whether that is clinically significant or not is still debate. Fatigue is probably the most common chronic complication of cancer treatment, and fatigue is a harbinger of poor prognosis of functional dependence and of death in older cancer patients, not just cancer patients. So fatigue is something that really deserves our full attention now that other symptoms have been better controlled. Neuropathy may severely affect the independence of older cancer patients. And we really don't know whether cancer treatment is associated with an increased risk of dementia and active life and decreased active life expectancy. And these are 2 issues that need to be studied. And I hope that in the VA you have a unique opportunity to study that. I don't think we... The NCCN has established some guidelines. I was the first one to establish them now, and that recommend that the first dose of chemotherapy be adjusted to the renal function in patients aged 65 and older, that prophylactic filgrastim and pegfilgrastim was used in patients aged 65 and older receiving moderately toxic regimens, that some form of geriatric assessment is indicated for all patients 70 and older, and this is the other thing. My original recommendation was a use of erythropoietin up to an hemoglobin of 12, but clearly that is would not be popular right now. But certainly the control of anemia, I think, is an issue that needs to be remembered. And finally, I want to warn you against some worst conclusion. I believe in global warming, but I certainly don't believe that global warming can be inferred by the size of the women underwear. And so we have to be very careful in not thinking that everything that happened in older people is just due to old age. Thank you so much for your attention.